I want to thank everyone for joining today. Those of you who have attended these calls previously are aware that FX Campion usually runs these calls, but he is taking a few well-earned days off. So some of you may recognize me from the M-Code community of practice, but I'm another one of the physician informaticists at MITRE. I hope you all will join me in enjoying today's panel. This is the second time that this group has discussed contact tracing. Previously, we discussed a little bit more with regards to what is contact tracing and how it might be applicable. Today, we're actually going to get to the more applied side of it. After some introductory remarks by Dr. John Halamka, we have three presenters joining us today. We'll first hear from Ramesh Raskar. He is Associate Professor at the MIT Media Lab, and will be giving us a bit of the perspective from that angle. We'll then go to a clinical perspective with Dr. Ashish Atreja from Mount Sinai, who's the Chief Innovation Officer there. And then we'll close out with a more industry perspective, and we're grateful to have Catherine White, who will be talking to us a bit today about the Corona Warn app that has been developed internationally and is available open source. Throughout today's conversation, it is intended to be that there will be a brief panel discussion, and then the rest of the meeting will be very quiet if we do not get your questions. So please take advantage of the chat feature. We have several staff as well as myself that are going to be monitoring the chat throughout the call, and we'll do our best to get your questions over to the panelists as soon as we can. With that, I'm going to go ahead and get things started by handing the microphone off to Dr. John Halamka for some introductory remarks. Thank you.
Well, hey, thanks so much, and look forward to today's discussion. And every week when we get together, I always talk about the themes of the week and where we've been and where we're going as we are on this trajectory from isolation to testing and contact tracing to pre-vaccine return to work, post-vaccine return to work, and the new normal. And some themes that I'm seeing this week as we start thinking about the pre-vaccine return to work is asking, what are the possible cures? What are the possible therapies as we wait for a vaccine that we can use in the meantime? And of course, convalescent plasma and various products related to convalescent plasma, whether it's transfusion, hyperimmune globulin IV, IM, subcutaneous, remdesivir, dexamethasone. I mean, these are some of the things for which you're seeing early evidence of, if not perfect efficacy, of suggestions that it probably is safe and probably is a reasonable idea on the road to randomized clinical trials. So I tell you all this because really, if you watch the news over the next 48 hours, I think you're going to see quite a lot of discussion about convalescent plasma. And much of the work of this coalition and coalitions of coalitions has been on encouraging donors, building the website The Fight Is In Us, and trying to improve processes so that we have better distribution and collection of the various convalescent plasma products. We've talked in the last couple of weeks about how Operation Warp Speed, HHS, DOD, and other members of the federal government are now getting engaged in convalescent plasma. So again, in the next 48 hours, I think you'll see much more federal engagement and support for the convalescent plasma activities. So I think this whole notion of a constellation of activities as we wait for the vaccine is a really important theme of the week. But understanding who's infected and who they touch and where there are risks is very critical. And this notion of every state having a contact tracing strategy is key. So certainly look forward to the discussion that we're going to have in privacy protecting, contact tracing, and how as a country we can have an overall strategy that mirrors some of the best practices we've seen in other places like Germany. And hey, Ramesh, I'm sure you would highlight, based on our previous conversations, other countries that seem to be doing this reasonably well that we could emulate. So turn it back to you and the panel.
Fantastic. I think Ramesh will go ahead and begin with your discussion right from there. Again, a reminder, if you've got questions for the panel, please go ahead and put those in the chat. We are keeping an eye on that. And I do see your slides, so I believe you will be ready to go. Take it away.
Thank you, John, and thank you, Nishan. Ramesh Raskar, professor at MIT and also part of PathCheck Foundation. Let me tell you a little bit about exposure notification from Google, Apple, case management, and how we can use that for public health and back to work solutions. This audience knows very well what exposure notification is, which is Bluetooth-based proximity. Step 1, step 2, notify if you're cross path with good privacy and good speed. Number 3, which is not at all proven yet, is how does this actually help public health and business coordination tool, because the exposure notification goes to an individual, but doesn't necessarily help public health and businesses yet. And that's where case managements actually come in. So if we step back and think about kind of the National Weather Service for pandemics, right? I mean, what does a National Weather Service do, for example, in case of a hurricane, is you have a bird's eye view, literally through a bird or satellite. And then you also have a lot of prior spread models of previous hurricanes. And if you have the same two things for pandemics, we can probably do a much better job. And so the challenge, of course, is that unlike a hurricane, pandemics are about innocent people infecting other innocent people. And so that's why we need some solutions that allow us to use humans as sensors, right? And smartphones are actually a great mechanism for that. So what we're doing at MIT is we're creating mechanisms for states and nations to start using smartphones for this mechanism. And we think there are 4 main challenges states are running into: privacy, adoption, cost to develop and deploy, and any connection to public health, which I said remains as an open problem. And actually today we have a great event that just wrapped up. And then we have another event coming up on August 5th and 6th. And actually John Halamka and many of you will be part of that conversation next week. So we really need kind of a national kind of a coordination strategy as we start thinking about this pandemic. So a little bit about PathCheck Foundation. It's a spin-off from our group at MIT. It's helping states and nations launch their apps, not just exposure notification, but also case management. And the good news is that PathCheck is the leader in this space, has contracts with US states, multiple US states and nations, and right now already has entitlements in 8+ jurisdictions. So more than 50 million people in kind of, in the states and nations, that PathCheck is working with. And it's also become the world's largest open source nonprofit project for COVID-19. And fortunately, it has a lot of long-term philanthropic funding to hire a full-fledged software engineering team, in addition to epidemiologists, privacy experts, ethicists, and so on. And it has 2 basic parts: the app, which is the app that has exposure notification, personalized guidance, symptom tracking, very soon quarantine verification, and so on. And on the right is the dashboard for public health and businesses to improve manual contact tracing, hotspots, spread prediction, coordinating people, population at home, and so on. So the platform itself is agnostic to which technology it uses: GPS, Bluetooth, Wi-Fi, QR code, and others. But of course, the very first solutions are being deployed using the Apple-Google protocol. And so the foundation, provides not just software, but also insights, and works with a lot of partners. And this is probably an important slide for many of us, because on the left, we know how to do this in a manual contact tracing manner. There is contact tracing, which is identifying contacts. Second is triaging. Third is monitoring, test, isolate, and so on. When you try to do the same thing with digital, which is shown on the extreme right, all you have is exposure notification, maybe on-phone symptom checking. So what PathCheck is really doing is combining the 2 efforts, the manual and digital, connecting it to case management, and connecting it to the public health infrastructure with privacy and scalability. So if you think about an individual's experience, it's not just exposure notification, it's triaging, testing, quarantine, and exit from quarantine. And any software company can just come and deploy a solution like this for a state or a nation. The challenge is, how do you do this for individuals as well as for businesses in a privacy preserving way? That means no name, no email, no national ID number, no personally identifiable information, and still take the individual through the whole flow. So if you think about this, I'm going to skip this slide. If you think about this, you need a foundation, a nonprofit, to really kind of put all these efforts together. So I'm delighted to work with some of the smartest people who have taken a pause in their career, and I decided to dedicate their life for the next, in the last several months, but also for upcoming year, to work very closely in these problems. And so we cannot think like a for-profit, we cannot think like a startup, we cannot think like a corporation, we cannot even think like a traditional nonprofit. It's just a unique architecture and unique formation we have here. And then finally, what does it mean to create a good smartphone-based solution, right? As I said, it should be built by a nonprofit, because if there's a 60% penetration of an app in a state or a nation, that's unprecedented view into people's lives, even if you use the Google Apple exposure APIs. Because even the metadata alone, just the IP addresses in combination with ad tech data can create temptation to use this data in other ways. It should be open source so that there's trust, avoid vendor lock, interoperability. And finally, it should be more than just exposure notification. It should connect to public health and reduce at least 50% cost of manual contact tracing, multiple languages. Right now, our estimate is that a exposure notification and contact tracing app will cost 10 cents per person per year, while manual contact tracing operation will cost $30 per person per year. So in a state like Massachusetts, it's about less than $1 million to run these services. Thank you.
Great, thank you, Ramesh. As we are getting ready for Dr. Ashish's presentation, just a reminder that if you have questions for any one of the panelists or all of them, please go ahead and put them into the chat. We'll save them there, and then as we get to the discussion portion of our presentation, we'll go ahead and bring those up. So it looks like, yes, we do have your slides, so over to you. Thank you.
Wonderful. It's great to follow Ramesh and kind of give what we call as a AR perspective, which is alternate reality perspective, the voice of health systems. And a lot of what we see in digital health is how digital health can unify the traditional fields of public health, population health, and medical care. So a lot of my plea is, while a lot of the contact tracing work is happening from labs to public health agencies, how can health systems actually meaningfully contribute and really make the contact tracing app also much more worthwhile for people to download? It's one thing if patients download it just for contact tracing, but if we connect with all the services which can help the patient throughout their journey of COVID and prevention, it becomes, instead of punitive, it becomes very rewarding for patients to download. So I serve the role of Chief Innovation Officer in Medicine at Mount Sinai Health System. And as many of you know, we were at the epicenter in April and May. And we had to rapidly build technologies before we had this privacy and all these other Bluetooth connections and solutions there. So I'm going to share some of those findings and how we can actually continue to work together with MITRE, and also share some of the international perspective that we had. So I just wanted to talk about contact tracing and beyond. The challenge which we face as health system, and most of the health systems in New York and now across the nation are facing, how do we support our patients, our communities, as well as our employees during COVID crisis recovery and new normal, right? And a lot of the stuff we felt is, we also felt if we look at the journey, contact tracing happens when a person has gotten an infection. But can we really augment prevention part of COVID and reach out to millions of patients at once? So I'll share some of the examples where we reached to 850,000 New Yorkers using electronic health record and actually gave a whole workflow for them, how to prevent getting COVID. And this is especially critical now because of the different reopening that's happening in different states. Patients are getting very confused what they can and cannot do. But if we do diagnose something or they have symptoms, how do we triage and guide them so they do get to the testing? And once they get to the testing, the contact center can take it from there. But also, how do we monitor our most vulnerable population, our employees, and really take care of emotional health as well? So in partnership with RX Health, which is a spin out from Mount Sinai, we had created 5 tools which can actually be augmented, and they are now available through Epic, free of cost through Epic App Orchard. So one of them is we rapidly created a knowledge base so people do not have to struggle. They don't just query CNN or Fox News or something and find what is the most updated information, but rather it is curated from CDC, WHO, and peer-reviewed literature for patients in a patient-centric manner. But then connecting with the triage tools with a bot so people can identify they are at high risk or low risk and where they can go for care. We felt because the traditional face-to-face care tools were not there, patients have to be available virtually through text to enroll features, and then link them through telehealth and in sometimes face-to-face if that's needed. But really for the highest risk, we also do device-based monitoring and actually prepare them when they go back home so they do not actually spread the risk among other family members and their community members. So very rapidly within 2 weeks, we launched Stop COVID NYC initiative, which is a text to enroll program. And we had reached out to 850,000 New Yorkers using self-enrollment and also from electronic health record. So Ramesh, as we are talking about the SafeCheck app, I think part of it is how can health system actually reach out to all the patients they have and actually bring it as part of that app ecosystem. And 55,000 people enrolled into that. We were digitally monitoring them. So I think that's the power where we can combine forces from health system part. We also started doing a lot of employee facing through very simple SMS based with GL New Haven, and also reached out to vulnerable population, which are the highest risk. So we are now creating a cohort of post-COVID cohorts because a lot of the patients may have side effects, but that triggers at the time of diagnosis. So we tell them how to be safe and how to keep their family members and community safe, but also how we can keep a track on our employees and actually create dashboards for monitoring. Being a health system has advantages that we can actually do a lot of the contact work and actually have IDs of the patients. So at some stage, if we can plug in referral sources to the neighborhood health systems and the patient chooses that or the participant, then we can turn on all the care we want to give them. And we don't have to unlock the identification initially. So a part of our work now is going with Indian government. So I'm part of the Medical Advisory Council for Swasth initiative, which is one of a kind initiative where BCG Consulting Group has set up a nonprofit initiative where most of the health systems in India are now part of. And they are managing 10% of the visits to be done free. So this is creating the first of a kind telehealth backbone in the entire country. And it's again open source platform. And we are now bringing all the work that we have done in New York and Yale, actually embedding them through a module within that initiative, where people can not only do the contact tracing from Arogyam app, but they can actually use a Swasth initiative to check their symptoms, to actually provide real-time data and actually volunteer themselves for plasma, which John alluded to in before. So I think a lot of our effort is how do we bring all those care programs, which have been done in a very meaningful manner with national initiatives, and actually make public health and health system population health together. So in the interest of time, I'll just leave with this last slide, where I really see barriers to contact tracing efforts in US. It's very tough to achieve 50 to 60% penetration in US when we cannot convince our population to wear masks, which are very evidence-based strategy. But at the same time, we're looking at a long-term role, maybe for the next pandemic or something, we build the infrastructure which can be scalable and sustainable beyond COVID. And really by bringing a lot of the stuff which health systems, universities are doing, health plans are doing for massive outreach, combining those efforts with a contact tracing app and a customizable toolkit so individual person or organization can choose what goes in or goes not, will be something that will be really helpful for us. Thank you very much.
Great, thank you, Ashish. Let's go ahead and turn the slides over to Catherine's presentation. And while we're getting her presentation set up, I've seen a delightful series of questions coming in through the chat. Please continue to go ahead and continue to submit those. And are we, there we go. I was not seeing the slides. Again, please go ahead and continue sending the questions over to the chat, and we will take those when we get to the discussion portion of our presentation. So, yes.
Can you hear me fine?
Yes, we hear you fine, and your slides are up on the screen.
Yeah, thank you. It's such a privilege to be here as a MITRE alum, and I've got my MITRE artifact in my background. I know how important MITRE's mission is to really solve the world's hardest problems and to bring all different kind of people together to address those problems. And so that's why I think this is, such a unique opportunity to make a difference. So it's a privilege to be here. I am part of Deutsche Telekom, specifically the T-System side, and I want to spend a few moments up front telling you about some of the things we've learned in the Corona Warn app, a partnership with SAP and a number of other players that I'll walk through. I think as you heard from Ramesh and Ashish, we have to look at both the system and the trust to be able to break through in a meaningful way in an environment where time really does matter. And so we've had this app solution, let me call it that, available for a little over a month. We have 16 million downloads, primarily in Germany, but it's now available in 29 countries across Europe. We've engaged the open source community, and of course, it's also available in open source. It's available on GitHub. So as part of this coalition, as part of the partnership with MITRE and all of us, I invite you to take advantage of the asset that's there because it is for all of us. If we could go, MJ, to the next chart. Whoops, looks like I'm getting a phone call. If we could go to the next chart. Do you guys see the next chart? Just I don't.
Can you see that?
It hasn't advanced on our screens yet, MJ.
No?
Not yet. Perhaps, Catherine, if you could just continue talking to the slides and we'll get them up as soon as we can.
Okay. Yeah, so I think in the next slide, what we wanted to do was address the system holistically. So we digitized the processes around the safety of the person, and then looked at the coalition. Yeah, here we go. It may be a little bit easier if we go to the next chart. MJ, can you advance?
Yeah, I advanced. Delete that.
Thank you, Susan.
Got it?
Thank you. Okay, so I was going through that we actually didn't set out to develop an app. We were looking at, what can we do quickly to interrupt the infection cycle? And you heard about this both, from the previous panelists as well. So we looked at the digitization of the testing process, which also allowed us to look at the digitization of contact tracing. So as a result, from the very beginning, we were looking at this holistically. it did result in an app, and it does give us proximity tracing, but it is done with, the highest of transparency, privacy protection, security, zero rating, lab and healthcare integration from the very start, and of course the support hotline so that the users have support from the very beginning of this. If we go, Susan, I guess to the next chart, I thought it was also interesting to take a step back in terms of, how did we engage the ecosystem from the beginning and what principles we set forth, again, at the initial onset of the project to ensure that in the first instantiation, we'd have something that was built off of that systems approach and that open and transparent necessity. So I already mentioned the partnership between Telecom and SAP. There were partnership across a number of different aspects of the German government, medical, academic, just a holistic approach that needed, therefore, a set of very clear principles. So it needed to be simple from a user experience, barrier-free, multilingual. It needed to have a minimum usage of data, no private data, no personal data, no GPS data, no access to your local phone data, and of course, no burden on your data usage. We wanted to use standard technology, so it's Bluetooth, low energy. Speed matters across, again, the entire system, so that the time to impact is as short as possible. And then, of course, the security throughout the system and the transparency in terms of the number of eyes, the number of the open source community, and as well, transparency throughout the entire process. So just the last chart that I wanted to then touch on before we go to questions is, as a result of approaching it this way, we're going through the simplicity of registration, how you opt in, no personal data, the tracing. I mean, again, many of the things that Ramesh and Ashish said were critical in their approaches as well. But importantly, the connection to the notification and the testing and verification process, so that transparency is across each touch point. Now, the government and the Robert Koch Institute daily reviews 3 key metrics, which I think are key to adoption. The number of downloads, okay, that's easy, but then also is the app being actively used. And thirdly, the number of positives that are being reported through the app. And those taken collective holistically will give us, the true engagement levels that then will make a difference in terms of the impact of the app. So maybe in terms of some of the Q&A, I can address that more numerically, but that's what I wanted to do to set up the questions. Thank you, and sorry about the mishap.
Fantastic, and I hope you will all join me in thanking each of our panelists for their initial presentations. We now have about 30 minutes to go into the question and answer section of our presentation. And to begin with, maybe we can just address one of the a quick question from Taylor Winkleman with regards to the costs of contact tracing. So this was specifically to clarify a little bit the cost of manual contact tracing versus the cost of an automated approach. And then perhaps we could go into what if the others have experience with regards to that point, what they might have to share. So we'll start with you, Ramesh.
Yes, first of all, I think it's not apple to apple comparison between manual and digital contact tracing. And maybe the most important point here to say is that when any ecosystems becomes digital, the first comparison is, does it compare with what we're doing in a non-digital way, right? So any digital transformation goes through 3 phases: improve, transform, and disrupt. So right now we're doing this comparison with manual contact tracing, but the real benefit of the digital solution is going to transform how we think about epidemiology with tremendous amount of data, and then it's going to disrupt, not just try to solve the problems, but it'll be preparedness. But coming back to the current comparison of improve, because in the beginning it's just comparison with existing non-digital system, PathCheck's quotes are roughly in the 10 cents per resident per year. So state of Massachusetts, roughly 7 million people, will be $700,000 a year. And manual contact tracing, which quotes have been given by others, not by PathCheck, is about $30 per person per year. So that's about $200 million. So if you do it for all of US, it'll be about 10 to $20 billion to get all the manual contact tracing in place. And for all of US, it'll be less than $20 million for an app-based ecosystem to up and running. Provided we use nonprofit, open source, and all the other good stuff.
Fantastic, thank you. And Ashish or Catherine, any sense of what the economic costs of the implementations of your systems has been, or any early data on those fronts?
Look, I think cost is a slippery slope. You know, what's the cost of not doing it? I think that it also depends on how holistically we address this, right? So I think getting your scope right and being clear on what support you're going to offer is where the real cost and benefit analysis lays.
Yeah, and if I can build on that conversation, what we have found is through digital health prescription, which we have integrated with electronic health record, and now available through Epic App Orchard to 80% of US academic hospitals, the cost for us to distribute or activate or inform one time is less than a cent, right? So that's how we were able to reach 850,000 people. And if you look at the network of health systems, which can actually potentially prescribe it, the cost is minuscule. The daily monitoring cost depends. So we have also got wise in how to do it. So initially we were doing daily SMS-based updates. Then we created trigger points. So whenever the person's status change, then they can remotely invoke a bot or trigger a call at that time. And through that, the cost decreased for us to around 5 cents or something in a matter of month to actually less than 2 to 3 cents per month. Again, so it depends on, we can provide the same kind of a facility and functionality without increasing the cost as we get wiser. If you go to an app, the cost really becomes negligible, because then the person has an app and it's all cloud-based, which is very simple. You don't have to pay for API for all those. But the challenge we have seen is adoption for apps initially has been really, really big challenge. And we had to turn it on for majority of our employees and for majority of patients. So we see app as a long-term strategy, especially for patients who adopt it and are willing to do it, if cost is a major barrier. But SMS-based strategy or activation digital health prescription to onboard with bots as really the dominant strategy for us as of now.
Sishan, there's another point I want to mention on cost. I saw something in terms of the design approach that we took, where it was sort of one effort in the technical solution to 4 pieces of effort for building the trust and transparency to address this adoption point. And I think maybe that equation, while maintaining the privacy, the GDPR compliance, whatever the security requirements are, that's another dimension of cost. But just thinking of that 1 to 4, I think helps put some perspective on what success looks like.
Fantastic, thank you, everyone. To folks in the chat, if you would like to ask a follow-up question, please do so, and we'll get to the questions we can as time permits. Catherine, I actually want to pivot off of a point you just made with regards to the trust. And each of the 3 of us, of our presenters today, mentioned in the early descriptions and the early discussions of how you were thinking or the principles of your products, how critically important privacy was with regards to the very fabric of your apps. So Catherine, we talked about this briefly in the prep session, but I was hoping you could spend a few minutes and talk a little bit more about some of the privacy considerations you had in the design of your solution. And then Ashish and Ramesh, I may ask you all as well for how that played into your design thoughts. So Catherine, do you mind?
I mean, it was more foundational than anything else that we did, in terms of who we engaged, how we engage them, and ultimately the solution we came up with. So, you would not get that kind of adoption, particularly in Germany, without building the trust and transparency from the very beginning. So the teaming with the privacy organizations, regulatory bodies up front, and engaging with the open source community, so that they literally were part of the transparency in the development and deployment. So there's trust built at both a regulatory and engagement model, as well as just the design aspects itself. So we're not getting GPS, we're not getting location data, we're getting proximity, we're getting the minimum amount of data from a design standpoint. So again, we're building trust, and I will be transparent with you as well. A lot of the questions that do come into the hotline relate to, the data privacy and integrity around which that's built for the people who aren't involved in the same level of day-to-day details. So it's taken super seriously and will not be compromised. And to that end, having the COVID care environment built around a scenario where there is not, and we have to design this in a way that we're not choosing between having health data and being safe, right? Having the privacy of my data and being able to engage in a safe way is the foundation of the design approach that we've taken. And I think that all of us want. I think just doing that, is the design challenge, and one that we will not compromise on.
Fantastic, thank you. Ashish, please.
Yeah, so our kind of advocacy or kind of efforts at the grassroots level was slightly different, because we were coming from a health system approach. And while we didn't have to worry about de-anonymizing everything, we still have to do all the HIPAA and the best practices. One of the things which we had seen in COVID is organizations which have already gone through using digital tools before, they already had fundamental capacity. And it was easy for them to rapidly turn it on and do it. So the Stop COVID NYC initiative was done within 1.5 weeks. And it was just because 4 years ago, we launched the platform for digital health prescribing. And we had around 25, 50 initiatives across different diseases, where we had gone through IT security to validation, to patient adoption, to publications, how to engage the patients, and really what the patients want. So a lot of our effort was taking what we have already seen patients wanting, their needs from a knowledge perspective, from action perspective, from a referral to care perspective, and we were able to mold them together. But the pandemic helped us because there was a sense of urgency. At one stage, 900 out of 1,100 patients were all COVID, and we were taking care. So the IRB regulation, which had to approve it at a record time, which I've never seen in my life. Right. So there were certain blessings which happened where we knew that if we align ourselves from IT standpoint, from IRB security governance perspective, from app building and the patient centeredness perspective, everything came together so fast. So a part of that I'm already started to miss. That may go away as the urgency has, but having tested once, we believe we can anchor ourselves that we can come closer to that efficiency.
Thank you. Ramesh, any other comments?
Yeah, I agree with Catherine and Ashish. I think, like exposure notification is, think of that as just a scientific instrument, that gives you some notification. But, a thermometer doesn't solve, a flu season, right? So I think there's this unnecessary fascination. I'm a technologist myself, but I have to be careful. I think there's unnecessary fascination that, hey, somehow if we just have this awesome technology, everything else will play out. In reality, exposure notification technology is going to be more like speech recognition in the 90s. It's barely going to work. There are a lot of false positives, a lot of false negatives. People have their phones off. They'll forget them at home. 100 things will go wrong. And what matters really from an epidemiology point of view is that we create an experience that well beyond exposure notification. And as we have worked in many jurisdictions with many governments and many nations, I think it's becoming more and more relevant that we have to kind of shift the conversation away from this shiny toy called exposure notification and move to what really matters. And so would love to kind of share notes with Catherine and Ashish and others on this topic, because what we have done is we have taken all the CDC, all the WHO, all the state-wise guidances, and we have converted them into a workflow that really seems to work for the jurisdictions we are already in. And in fact, some of them have come from those states and nations themselves. So we sit down with them and figure out their workflow, and like being a very nimble, a nonprofit, we can do that. The second angle, which Catherine mentioned, is privacy. And privacy is one of those topics that, gets more in the context of, say, Facebook or Twitter, and not really in the context of an app that will be used by 60-70% of the population. So we're going to run into a lot of headwinds as people say, hey, I know that a for-profit company can mine just the IP addresses and other metadata and can use this in all kinds of amazing purposes. If a company from country X starts providing solution in country Y, why should country Y agree to it? We're going to run into a lot of headwinds into both of those directions of connection to public health, the first point we made, and the second is this kind of geopolitical tension about metadata.
Great, thank you, everyone. We did get one question from the chat, which is more of a question, I believe, seeking your thoughts and advice and experience in this. But we got a question around what would the path be for a state or an entity that has already made an effort like this, but may not necessarily have been as privacy protecting as first. And basically that first effort stumbled and did not succeed. Like, do you all have any thoughts on what a second attempt or how to win back the consumer might look like? And I'll leave it to anyone that might want to take that one first.
I can tell you that this was the second attempt in Germany. So it is possible to have a second attempt, and 16 million downloads is not, I mean, it's over 20 or something like 20% of the population. And in preparing for this, I'm sure my panelists know more about this than I do. But there's been some studies from Oxford and other data modeling that even if 10% of a population is using a contract tracing app, for every 1 to 2 users, 1 infection could be prevented. So we don't need 60, 70, 80% penetration to have it make a difference. So I think restart, embrace the failure that we've had, be as inclusive as possible in terms of creating that ecosystem, be very visible on your design principles, and use what the rest of us have already learned to not lose time. So I absolutely think that states, countries, cities, college campuses can restart and should restart if the first attempt didn't work.
Ashish
or Ramesh, any comment?
Yeah, if I can, I think Catherine's experience here is very helpful. I'm going to change the question slightly, which is say that other than the states and nations, I think a lot of employers and universities and so on, I think are likely to go through the same challenge that the states went through, which is they will launch a solution saying, hey, my IT department is so smart, they came up with a solution with badges or tags or things like that, or smartphones. We're going to deploy it. Isn't it awesome? And then the employees and the students and staff are going to revolt and say, no. Like, it's one thing for you to track where I am and quite another thing to track who I'm with. And there's going to be a revolt against that. So I think we're going to see this being played again and again. So my request, like all the employers and universities we work with as part of PathCheck Foundation, we say, yeah, you might know how to solve this problem, but you should still solve it in a way it doesn't seem to infringe on personal freedom. And then I have just a follow-up to Catherine, which is, given that SAP and T-Mobile are kind of, very strong German brands, how does this get received in neighboring countries where you said, what, 20 plus countries are
Yeah, I was just reminded of that from a colleague also to make a point on that. Again, I think it's the transparency. We're partnering with the EU around freedom of movement, and so it's a requirement to be able to trace across boundaries as well. So in addition to EU, there's some other European countries like Switzerland, UK, Norway, maybe a few others that are part of that coalition as well. So again, because it's so open and transparent, then we're able to strengthen the coalition, strengthen the usefulness of this through the countries. The thing that we haven't seen with every country is this 1-to-4 ratio. You know, the German government made a big commitment to communicate broadly to ensure that everyone understood that there were the support hotlines, et cetera. And so we have the interoperability across any of the apps that existed in any of the countries, as well as any of the 29, as well as the ability to download this app. So we are, you know, keeping the ecosystem open and strong. And we know there's going to be other aspects to the COVID care environment that will connect through in these open APIs. But we can't forget that having the solution isn't the same as communicating and giving the support to our citizens to feel comfortable and engaging. And that's where we haven't seen the same across all 29 countries.
Yeah, I think that's such an important point. And I'm assuming, given the good relationship Germany has right now, there's not as much pushback for us, other countries saying, why is Germany hosting the server and so on?
Yeah, and also, you know, can be hosted. I mean, normally EU hosting, it's okay, you know, from a European Union perspective. But if it was a concern, of course, that can be addressed.
Right. Zishan, I just don't see that happening in the US amongst the states. There's so much, you know, dynamic arguments one way or the other. It's unlikely we'll get a cohesion in the US.
I personally try to always be optimistic and then bring realism in from there, but I absolutely understand the concern. And maybe we can pivot on it a little bit based on a comment you made and something Ashish mentioned in prep, which was around employee monitoring and employer notification. And Ashish, I would love for you to expand on a comment you made in prep yesterday around, you almost had an encouragement for health systems to get involved in contact tracing, despite some of the complexities that they might face in some of these perspectives. So maybe you could start with that and then we'll open the conversation.
Absolutely. Thank you, Zishan. So I think I'd like to resonate one comment which Ramesh made. We all have this tendency to pick up the shiny object syndrome. And we tend to say the solution lies in only this technology. And once we start kind of really getting hands-on with the technology, we start saying, oh, it's, you know, what is being said, we know Khosla said, 6 iterations that it goes through before it really becomes really like a smartphone from a big phone, right? So from our side, I think it was we were benefited because we did not, when we went into pandemic, we did not have luxury of all this contact tracing part. And we had an immediate need. So we actually went with more problem-first approach than a solution-first approach, right? And what we unearthed was there's so much other things needs to solve, right? From care perspective, from adoption perspective, from prevention perspective. How do people prevent getting COVID, you know, as things are reopening, right? What are the best practices, right? As there's a mistrust in what you can get on the web, right? So with the recent viral video, if people watch that video, we have to counter that. So I think part of us is we actually did not, and we knew contact tracing is coming. We've been in touch with Apple and Google, but we felt we had to solve the solution anyway, the problem. And when the contact tracing part gets solved, we can always integrate that in a modular fashion, right? So as part of that, one of the things that we did for our health system at one time, 30% of our employees were not available, or they were down with family, or they were sick. So we had to do capacity building very rapidly. So we did this, and now we realize the same thing we did for employees would be relevant for employees in general as people are working for recovery. So solution can be extended in that. And one of the things which we have learned a lot is even going from one health system to other health system, there's so much nuances that you have to customize the tool or the toolkit. So a lot of our effort has been creating a modular approach from an architectural perspective that if contact tracing per se, because of privacy and confidentiality, is not relevant for a university or for that, they still get benefit of everything else, right? They still get access to a hotline. They still get access to a monitoring. They still get access to video visits. They still get access to mindfulness programs, prevention programs, or post-discharge programs, right? So that way, instead of us forcing something, We say this is a modular, customizable digital toolkit, which has all those assets, and you can take based on your governance model, any one of those assets you want, but at least get something. So you start making a difference, what Catherine mentioned, 10%, even if not 80% of people, but not have 0 or 1 phenomena. If you're just stuck on this part, then you get nothing and you lose all of the value there.
All right, thank you. Catherine or Ramesh, any comment?
I think it's well said. I mean, to the degree that the COVID care environment is a set of collaboration across the community and different aspects fit into this, of which the contact tracing is one piece. I mean, that's the way we're going to have to advance our collective efforts. I just add that it's doable. The 10% is achievable.
Yeah, I'm going to, Zishan, if it's okay, I'm going to say something that hopefully doesn't offend our friends in public health.
Please do.
Which is, it's also, there's a question here. We have, have been involved in digital health for a very long time. I set up, large health innovation teams at large companies and so on. But we as a group have done a horrible job in moving innovation forward. So on one hand, you can just imagine that Apple, Google, and some tech players have actually come in and said, in a matter of weeks, let's create something that moves the whole field forward, right? And created this shiny toy that everybody's attracted to. So like, at least we can imagine, like Catherine said, 25%, I think she said, at least get them going with this brochure. And what Apple and Google did, by the way, this is something that PathCheck Foundation tried to do and we failed, which is we came up with the very first contact tracing solution in the US back in March, and we made it extremely dependent on public health. It's like, if public health does X and Y and Z, this whole thing will work. And that was a mistake because they move very, very slowly. What Apple and Google have done, if you think very carefully and read between the lines, Apple and Google have eliminated the dependence on public health, because all they have to do is say, this organization, please build the app. And after that point, public health have really no point to play. It becomes a very consumer to consumer play, right? You get exposure, the whole system runs purely in a consumer fashion, and public health has no role to play. After you get exposure notification, you can call your number and get tested and so on, but they have eliminated the whole process. And this is, in a way, a kind of just a kind of a very gentle and sweet slap to us in digital health. So, as much as we want to kind of get into the analysis paralysis mode of this, like, I wish this was there and this should be there, and only when all those things are done, and there's a lot of political correctness about, who should get the service and what about this community and what about people who don't have smartphones. I think Apple and Google have done kind of the right thing and just kind of kicked us saying, let's get going.
Fantastic. I'd actually like to take our conversation and build a little bit on something you just said, not to dissuade our colleagues in public health, but more so around the consumer experience of these applications. And so each of you have mentioned in some way, shape, or form that these applications don't succeed without the individual being willing to install the app and get some benefit from it. So for this segment of the conversation, what I'd like to explore are some of the ways, perhaps Ashish, your ecosystem builds on this, and this may be the easiest for you to start with, but what have you found to be the incentive driver that made the consumer willing to download this app?
Right. And that's a fundamental question, right? You look at motivational factors from individuals. And I would say there's different factors for different people. I also lead a coalition of around 32 health systems, which work together on digital transformation and innovation called Node Health. It's an association for digital health. So we learn a lot from other health systems and different kind of populations, which we may not even have access to sometimes in New York City. So we have found two predominant themes out there. One is there's such a big of anxiety around this that the people are thinking about their survival and their family member survival. So if we are able to, and they are also finding that a lot of the health systems do not have traditional way. They can't just call a doctor or show up to a doctor's office, right? That may not be open. at least during the pandemic peak. So they are looking to absorb any single thing that comes from the health system, which is validated education or empowerment, because they're getting mixed signals throughout the US, what is valid, what to do, what not to do. And the person they really have trusted in the past, their physicians and their care teams, they are looking for, what is my doctor saying? Should I wear a mask or not when I go out there? So I think that anxiety part and keeping the family safe, that fear factor is one that was a lot of motivating. So we felt creating resources for them, a helpline, knowledge base, continuous interaction, build that engagement where we can then tell them, hey, we recommend using this app for contact tracing and those kinds of things. So we can actually create that. And the reason that is important is, unlike countries like Korea or China or something, we are not gonna see in reality any upside down from a government mandate around an app in US, right? So in the absence of that, there is no way we can get 70, 80% penetration. What we can do is use the community, the public health, and the health system and the trust which patients already have to actually go to whatever level we can. So that fear was one. The second thing which we found was people, as soon as they felt they could contribute, they wanted to contribute, right? So we actually added a volunteer pathway to them in the process. So they can volunteer, whether they can volunteer their time, or they can be peer educator, or they can do convalescent plasma donation or something, or they can outreach the validated things to their WhatsApp groups or other groups. So I think people have this innate capacity as they get from the fear, they want to empower others as well. So we used kind of those resources where they can disseminate through social media and kind of make things viral. So I think between those two and constant reinforcing, without being, without getting on their face every single day, giving them ability that they can be more engaged or they can be less engaged in how they want, because they're different strata of the people, how they want to engage in a manner they want to engage, email versus chat versus phone calls or others. That flexibility was very important, we felt. I'm sorry for this mouthful answer.
No. That's my role here. Catherine or Ramesh, any other comment?
I'd reemphasize my point on the 4-to-1. And if you put one amount of effort into the solution, 4 times into the trust and transparency, the engagement, and in both of those, continue to improve. I mean, it sounds super simple, but it will work.
If you can ask a quick question to Catherine on that, I think it, it's such a wonderful message. How can states or even nations that don't have as many resources do that? Because I think it's as good as an idea that is. It sounds like it requires a lot of resources.
Well, I think you've got a lot of the answer, in this panel and in this consortium. Don't reinvent, but do restart. And when you restart, bring in, the coalition that matters to whatever community you're, whether it's Mount Sinai, whether it's a state, whether it's a city, whether it's a campus. You bring together the equivalent ecosystem to then create the care environment, of which contract tracing is a piece of it, as opposed to the answer. And I think, I think the community will know, especially if they've had a difficult start, but more importantly, if we share the things that we've learned about what makes it successful, to then have that right grouping in the state or whatever the deciding body is, that they're all in it together from the beginning. I think it's possible.
Yeah, we work in certain countries and also one of the states in the US who has no ground game. And they're hoping that a top-down technological solution could work. And maybe not in the first round, but we know when the operating system level exposure notification is going to start, hopefully in the next few weeks, we will get automatic 60% adoption, even if you have no app installed. So there is something there. So, but I hear what you're saying. I'm just kind of putting on the hat of the people who have no ground game and what they're going to do.
Yeah, and we may need to have, we may need to say, you shouldn't start unless you've got some ground game in this, right? So, we have to make the choices too, in terms of, if you don't have the ground game for the state, do we have it in a city? And get the city successful to then expand from there.
Absolutely, thank you. Well, we're reaching the close of our time together. Before we leave, I would like to offer a brief closing comment to any of our panelists that would like to take one. Any last bits of wisdom that we may not have touched on today that you'd like to impart to the community? And perhaps we'll return to speaker order. So Ramesh, that puts you in front.
Well, thank you, Zishan, and thank you for the coalition. Thank you, John and Brian, for inviting me. I think, at MIT, we are really thinking about this as the National Weather Service and what components of the system do we need for a national pandemic response service. And we're working very closely with many parts of the government, many nonprofits, many for-profits, of course, Google, Apple, and Microsoft. So that's a really good pieces that come together. I encourage you to join our boot camps. So it's less discussion and more boot camps if you want to join that conversation.
Thank you. Ashish? Ashish, I believe we have you on mute.
Sorry. You improve, then ultimately you disrupt. And I believe one of the stuff which I feel is really empowering about digital health is it can really unify the traditional fields of what disparate people may be doing, public health versus medical care versus population health versus other governance and advocacy. And while we are doing this, I think we do not have time right now to digest everything and learning, but we should continue the learning, especially as finally the pandemic gets over, and really say the infrastructure that is getting built, how that can really unify and bring all the fields together. So next time we don't have to fight the same advocacy battle, the same public health building infrastructure problem. Those pipelines are built and we can actually really empower something which is disruptive and not just improvisation.
Thank you. And Catherine?
My final word is time. Time matters. Flu season is coming. We know that in the Corona Warn app experience, that there are 2.5 times more positives in the app than outside the app. We're saving lives. Let's work together. Time is against us.
Call to action. I love it. Well, with that, we're going to bring this discussion to the close. In this virtual environment, and I hope you'll all join me in thanking our panelists. You've all certainly made this a very easy discussion to moderate, so a personal thanks as well. Again, the recording is going to be posted online. The links have been made available, and if we did not get to your question today, we will make sure to get those to the panelists. Thank you all for joining us today. We'll have a conversation next week on vaccine development that will be moderated by Dr. Brian Anderson. Have a great week, everyone. Goodbye.